Good afternoon, everyone. Shall we start the session? Sir, shall we start the session now? Okay, sir. Thank you. Sir, you have to do the introduction today.
Hello, everybody. Am I audible? Can you hear me?
Yes, sir.
Yes, we can.
Good afternoon. This is possibly also an occasion, quite an occasion, because you have changed the format now to a shorter session, an experiment. Very glad to see that so many are still with us, but maybe not so happy to see that maybe the attendance has come down from the time we started. Very glad that at least this group is still intact. Vidya, Mary, Farzana, Betty, Nandini, all at Cancer Hospital, Lincoln and others. John, hi. Vijay, thank you. Vijayanand, and everybody else that I cannot see right at the moment. Glad to introduce today's echo. Thank you, Vidya, for asking me to do it. John, this must be a dreadful time of the night for you, right? John? John, have you connected with us at a terrible time of the night? I don't think he is with us yet. Friends, I am very happy to introduce a guest faculty member, Dr. Vijayanand. I've known him for a few years. I have not really worked closely with him. I wish I could. Very glad to see that he has moved closer to Trivandrum in Coimbatore, not so close that he can see frequently. The reason why I said I am particularly glad that he is with us is because he represents pain physicians who care about the whole person and not just about pain. I do not say this with any derision for people who see only pain, because I know that for many years I was one. I at one time saw only pain, not the whole person suffering. I believe that Vijayanand is able to see the whole person and cares about the human being. So Vijay, thank you for being with us today. Great privilege. And I don't know if you have been listening in on any previous echo after your presentation. We are sure we will have a very active discussion. So, does everybody here know how Vijayanand is related to the coordinator of ECHO, Dr. Vidya Kumaraswamy?
Very unfortunate relationship.
Vijay, are you better with life?
Very much so.
Okay, Vijay, over to you.
Shall we start the presentation? We have to share it from Pally Media.
Yeah. Good afternoon, everyone. Thanks for the introduction. It's a bit scary, actually, to see people in such close quarters. I was nearly tempted to borrow Vidya's lipstick and mascara, actually, just to look better on screen. Now, we're going to talk about neuropathic. Dr. Rajagopal mentioned, we do sort of look at pain as a biopsychosocial phenomenon and try and deal with it at different angles. But this afternoon, we're just going to focus on the biological side of things and a few sort of non-pharmacological methods as well, because talking about psychology would be a little bit too much. Can I have the next slide, please? Yeah. Okay, can I have the next slide, please? Yeah, no, the one previous. That's just going
on. Yeah, previous one.
Previous, yeah. Yeah, yes, that's right. Yeah, that's fine. Thanks. Yeah. Now the thing is, neuropathic pain is an enigma for most of humans, so to say. At least us as doctors, we have some clue about what's happening. It's much more of a problem with the patient trying to understand, what's happening in their bodies. Why should no tissue injury result in such pains? And this is an image I lifted out of Dr. Google. You could see the patient's drawing representing trigeminal neuralgia. And it's a neuropathic pain condition where 80% of people have a tiny blood vessel crossing on the nerves, causing some sharp pains. It's called suicidal headache because the pain could be so severe that people commit suicide. And and 20% of patients don't have any pathology. You can't really pick up anything wrong on the MRI scans, and they still have the pains. So it's a tough one to understand. Next slide, please. Another example of neuropathic pain is the phantom pain, which again it's a tough one to understand. Next slide. Yeah. So this is a drawing again I lifted out of the Neuroorthopedic Institute run by Butler and Mosley, and this is how the patient feels when they have this phantom pains. And we're not going to look at the pathology and mechanisms this afternoon because it's a short talk. Here we will focus more on the treatment and maybe just look at a few ground rules what neuropathic pain is all about. So we'll go to the next slide, please. Yeah, so it's actually a syndrome caused due to different diseases and lesions. So there are many reasons why neuropathic pain can happen. It could be either due to peripheral nerve damage, or it could be a problem in the central nervous system involving the brain and the spinal cord. So you can see it can happen in the nerve pathways, right from the terminals of the peripheral nerve receptor up to the cortical neurons in the brain. When we talk about phantom pains, which is the second slide, it's due to changes. The same condition is next slide, please. It is not known why the same condition is painful in certain patients, painless in others. Now, if you look at a condition like diabetes, where patients do get neuropathy if it's a long-standing diabetes. If someone's got diabetes for more than 20 years, then it's likely they do have nerve damage. Pretty much everyone, at least 80 to 90% have nerve damage, but not everyone has neurological symptoms. Those neurological symptoms, again, it could be what is called positive. Now, it is positive for the medical profession, not for the patient, which is more in terms of spontaneous pains, evoked pains. Whereas for certain patients, they get what we call the negative symptoms, where there is reduced sensation, hypoesthesia, hyperalgesia, and things like that. So the same sort of nerve damage can present differently in different patients. So that's an important point to understand when it comes to neuropathic pain. Next slide. And as I say, I mean, we're not going to go deep into the causes, but broadly it's classified there's damage to the central nervous system, which is damage to the brain, and the spinal cord injuries and things like that, post-stroke pains, or in the peripheries due to damage to the peripheral nerves or the plexus, the nerve roots, or the ganglion. Next slide, please. So this is how we used to have a lengthy definition for neuropathic pain, but in their wisdom in 2012, they managed to change it to a very simple definition, which is pain caused due to a lesion or disease of the somatosensory system. Now, it's quite sort of a straightforward definition. This is a definition which is slightly different to the usual sort of pain definition, what we kind of quote IASP, actual potential tissue damage, sensory, all those things. This is a slightly different take to neuropathic pain. And some people refer to neuropathic pain as pathological pain. There's to differentiate physiological pain, which is nociceptive. Next slide, please. So some ground rules with regards to neuropathic pain. It is characterized by spontaneous pains, which could be burning, tingling, all sorts of things, or it could be evoked as well, which could be which was called what we call allodynia and hyperalgesia. We'll look at it in a little bit more detail as we go through these slides. And there could also be negative signs, which is like which have sensory deficits. Typically we see that in diabetic neuropathy. People either complain of a burning sensation in their feet. The air blowing across their feet can trigger off the pain, and just they would like to put their bed sheet on the skin, and that again triggers off the pain. And then you have a certain group where when they wear their footwear, they can't wear their slippers, and it's kind of a loss of sensation where they go and do some damage to their skin, resulting in ulcers and whatnot. And then you get the paresthesias and the dysesthesias. We'll have a look at it shortly. What is the difference between that? And just by looking at the character of the pain, whether it's burning sensation or tingling sensation, you can't really say what is actually the cause of the pain. Now, previously, this is about etiology. Previously, when we used to treat neuropathic pain, there is this rule of thumb where if it's burning, then you start someone on amitriptyline. If it's a tingling kind of sensation, then you start someone on pregabalin. Now that's also kind of out of the window. So just kind of going with the character of pain, it's tough to decide what could possibly be the cause of the pain, and it's also tough to decide what possible treatments would work for this patient. So it's just kind of looking at it objectively, and then kind of going ahead with the assessment and the treatment. And we use a lot of screening tools. We use the pain questionnaires. There are a lot of them. The LEADS is quite popular. It's called the LANS, LEADS Assessment of Neuropathic Symptoms and Signs. And then you have the DN4, which is Neuropathic, which is a French thing. And they also have the Pain Detect, which was developed, and I think it's popularized by the Pfizer people. And then, there's a good old clinical examination, which would help us. There are a lot of tools you can use, mostly all very simple ones, like using a cotton wool or a brush could help us diagnose, say, for instance, mechanical allodynia. All it needs is a brush, actually. And for punctate stimuli, all it needs is a blunt pin. It's a neuro examination which gives us much more information than all the fancy screening tools what we have. And then we have some advanced things which we use for testing. You can do some investigations like nerve conduction studies, and the recent things like what we call the QST, the quantitative somatosensory testing. But those are mostly research tools which very useful for us. So next slide, please. There are some other ground rules as well. So this is very important to kind of get our head around. The same injury, nerve injury, can cause different kinds of pain sensations in the patient, and the same pain, which could be a burning in a patch of skin, could be due to different injuries or different types of injuries to the nerves. A single mechanism. There are multiple mechanisms which can cause neuropathic pain. There is a polarization, there is a receptor upregulation, there is kind of reorganization of the spinal cord, there is reorganization of the brain. But a single mechanism can present differently, as different symptoms. And a single symptom, again, could be due to different mechanisms. So it's a tough one to get a head around, but this is a very useful thing, useful slide to remember. And most importantly, like any persistent pain, the intensity of symptoms is, does not give us a clue about the severity of injury. So it doesn't matter. It must be a simple sort of tiny demyelination spot in the nerve, which can trigger off this intense trigeminal neuralgia kind of pain. So the rule is same for any sort of persistent pain. And the tissue damage or the severity of injury doesn't really equate to the intensity of symptoms. Next slide, please. Yeah. And this is what happens with the different kinds of tissue damage. So the first one is a brief sort of pinprick where it is conducted and it's felt as a transient, painful, noxious stimulus. In face-to-face, say for instance, we kind of squish a thumb in a door, then there is an inflammation and we do have pain maybe for a week, where you can see the central nervous system, the column in the middle gets wound up a little bit and the pain intensity is much higher. So we have that area of injury. Following surrounding that is the area of hyperalgesia, where it's not actually painful, but when you press it, it becomes painful. And then when there is nerve damage, which is the last sort of thing which you're looking at it, a simple sort of a feather rubbing on the skin could trigger off some intense severe pains. It's just a cartoon, a graphic description of what why people should feel this simple sort of a non-noxious stimulus to be extremely painful. Next slide, please. So the diagnostic criteria, this is quite fashionable these days, particularly among the pain sort of community, that the pain distribution should be anatomically plausible. There is a history which should be suggestive of a relevant lesion or a disease, which is quite sort of self-explanatory. They should have sensory signs, which is negative or positive signs in the territory of the lesion which is present. And there should be a diagnostic test to confirm a lesion or a disease. Now, very often in clinical practice, that fourth test, I think I've kind of wrongly numbered it, everything as 1, but it's 1, 2, 3, 4. The fourth one, which is the diagnostic test, which confirms a lesion or disease, we don't really sort of pick it up. I mean, for instance, if you do a nerve conduction study and if it's a small fiber neuropathy affecting the feet in pain from diabetic neuropathy, it doesn't really pick it up. So it is not essential to make a diagnosis of neuropathic pain. So next slide will give us a little bit more information. So next slide, please. So out of these 4, if the patient satisfies the first 2 criteria, then it is possible neuropathic pain. And then you look at criteria 3 and 4. If you pick up any clinical signs, then it's probable neuropathic pain. And clinically, to treat a certain pain condition is neuropathic pain, the 1, 2, 3 criteria is more than enough. But if you do have a diagnosis, a certain investigation which confirms nerve damage, then it's definite neuropathic pain. So to make a diagnosis clinically that a certain person is suffering from neuropathic pain, we should definitely have 1, 2, and 3. And if it is 4, then it is kind of all the more useful. Pain in the distribution of the territory of the nerve, history which is suggestive of a lesion of a disease, there should be signs and there should be investigations as well. It's a fairly straightforward diagnostic criteria. It's a fairly recent one. I think it's a few years old, 3, 4 years old, and it is quite good in picking up, and it just removes a lot of uncertainties when it comes to diagnosing neuropathic pain. Next slide, please. And this is just a kind of plethora of what you could possibly see with the neuropathic pain in terms of signs. The first column, you have the quantitative tests, which we can all pick it up in clinical practice. We have hypoesthesia, which is reduced sensation, hyperasthesia, which is a sensitivity to a simple sort of touch or a sensation, hypoalgesia, where they feel reduced pain, for instance, a pinprick, which is normally painful, it is less painful in certain people with nerve damage, hyperalgesia, where a painful stimulus causes an exaggerated response. And then you have the qualitative, which is the allodynia, which is a non-noxious stimulus causing a painful response. Now, this we see that in painful diabetic neuropathy most of the times, the air blowing on the skin, the cloth touching the skin, triggering off pain, all those things. And then you have the dysesthesias and paresthesias that we'll look at in the next slide. Basically how unpleasant the sensation is determines whether it's a paresthesia or dysesthesia. It's basically kind of dicing a salami, actually slicing a salami. It doesn't really make much sense. For the patient, it's just unpleasant and it is painful. The third and the fourth column, the spatial and the temporal aspects, is not something which we regularly look for. It is more of a research thing, the dislocalization, the after sensation. This is just for completion's sake. But so these are the kind of signs you could pick up in people who suffer with neuropathic pain. Yeah, next slide, please. We'll have a look at a little bit more in depth about what these things are, paresthesias and dysesthesias. Basically, they're both sort of abnormal sensations. But if it is not unpleasant, it is paresthesias. If it is unpleasant, it is dysesthesias. Now, for me, any abnormal sensation is going to be unpleasant. Okay, so it's it's, as I said, it's basically, you know, trying to sort of tease out a few little differences between the different sensations what we have. Next slide, please. Yeah, so this is again a list of signs what you pick up allodynia. These are all sort of what we call the evoke signs, which the patient doesn't actually complain, but you kind of pick it up. Allodynia could be mechanical allodynia, brush allodynia, and things like that. It is pain due to a stimulus that normally shouldn't provoke allodynia. Hyperalgesia is increased pain from a stimulus which normally provokes pain. What is pressure for a normal person could be pain for someone with painful neuropathies. Hypoesthesia is reduced sensitivity to stimulus, and hypoalgesia is reduced pain in response to a normal painful stimulus. So you can basically get the slides and you can go through it. If for someone who's new getting exposed to these terms, then it's a little bit sort of confusing, a bit overwhelming, but you can have a look at the slides later just to kind of get your head around. So next slide, please. Yeah, so this is a very simple, stimulus response curve. What happens when someone's got nerve damage? You have the normal sort of stimulus response curve to your right, which is the yellow curve. And in injury, the curve just shifts to the left, which means an innocuous stimulus, which is what is touch for us, becomes painful for the patient. And a noxious stimulus presents at a much, it gets much more exaggerated. So this is again, it's a very simple sort of cartoon trying to help us understand, what happens in these patients. It's basically a shift to the left of the curve of the pain, the stimulus response curve. Okay, next slide, please. So I borrowed a few slides, and I think this one is quite. This is from Dr. Jain, Tata Memorial, and this is I think it's quite an old sort of an image which he uses in his teaching. This is from nearly 12 years ago. A young lady who came in with pain in her right arm. You could see the swelling in the arm with some sharp shooting pains going down going down up to the tip of her fingers. And if you look at the scan images to the right of the screen, you could see there's a small cell carcinoma the lung pressing on the brachial plexus. So brachial plexopathy is something which in particularly see a lot of neuropathic pains. It could be plexopathies, it could be peripheral neuropathy because of chemotherapy, HIV neuropathy, which again it's a very, very refractory and tough condition to treat. I don't think we have any drugs which have been trialed and proved to be effective enough in HIV neuropathy, so it's a tough one. Next slide, please. Next slide also has been borrowed from Dr. Jain. So I'm pretty sure a lot of people must have seen this, herpes zoster rash, which is getting healed, and 30% of people who do get this herpes rash go on to develop some intense burning sensation in their skin, which is a painful sort of peripheral neuropathic pain. Again, it's a tough one to treat. PHN is perhaps the most researched neuropathic pain condition, mainly because the damage to the nerves is in the skin, so you can do a punch biopsy and look at the nerve intensity and whatnot. So it's one of those well-studied sort of pain conditions, and the treatment not as good. So next slide, please. I wish I could talk a lot more on psychology and the social aspects, but we're just going to stick to non-pharmacological treatments. Now, this is just for completion's sake before we, not really completion, but just to kind of what could possibly be done. Now, this is something we use for teaching, but very rarely we use. I mean, if someone's got an allodynia where touch is going to be painful, no, massage is not going to help, isn't it? Same with acupuncture. If someone's got a hypoaesthetic patch of skin and you stick a needle, you wouldn't really sort of expect acupuncture to help. And heat, you have heat allodynia, you have cold allodynia. It's just a general thing. You can use TENS, if it's a specific sort of dermatome which is involved, you can put the TENS pads on either side of the dermatome to use it. But generally, again, if there is a reduced sensation, the general teaching, even among the physiotherapists, is not to use any of these electrotherapy modalities. I don't know why I'm even having this slide in here, but I think it's more of a general sort of overview. So next slide, please. So we'll go into the pharmacology of things where we have a lot of evidence. Now, before I dive in, there is something called the NNT, I'm pretty sure a lot of people in the other side of the audience would have understood the term. It basically means number needed to treat. Now, if someone's got a chest infection and all it needs is to get the sputum, get the bugs grown, and treat it with antibiotics, and the chest infection goes away. So we treat one patient, and that patient gets better. So the NNT is 1. Now, if you look at neuropathic pain, the NNT is pretty bad. Actually, if you look at gabapentin and pregabalin, which is the commonest drugs what we use, the NNT is 3 for most of the peripheral neuropathies and certain central neuropathic pain conditions, which means you have to treat 3 patients for one of them to get 50% reduction in pain, which means the other 2 either get less than 50%, no reduction in pain at all. Now, this is the state where we are actually, because it's kind of quite easy to think, neuropathic pain, I can start them on gabapentin or pregabalin and the pain would go away. It's unlikely that they would actually respond to it. And the other thing is, if you look at the daily dose and the dose regimen, which is the middle column, you could see the kind of high doses what is used in Western countries. Now, this is the recommendation from in Lancet Neurology, which is the FNS guidelines. You could see the doses there. Actually, this is the kind of doses which we rarely use in India. 1,200 to 3,600 milligrams and 3 divided doses of gabapentin. You give them 50 milligrams and they sleep for 3 days with gabapentin. So it's a tough one, but I think that's the kind of doses what we looking at which respond. So these are the first line drugs which have been recommended in Lancet, which is the AFNS guidelines. You have the gabapentin, you have the pregabalin, you have the SNRIs and the tricyclic. So you have 2 sort of anticonvulsants, which is the gabapentin, pregabalin, and you have 2 antidepressants, which is the SNRIs, the duloxetine, venlafaxines, and the tricyclics, your amitriptyline and nortriptyline. And you could have a look at those doses as well. Maybe you can share the slides so that you don't have to remember it now. Next slide, please. And they have a long list of weak recommendations, which they talk about second line and third line drugs. Capsaicin 8% patches, lidocaine patches, and tramadol. Now, tramadol is freely available in our country. Lidocaine patches used to be available for a very short while, but because there wasn't a market, it has been sort of off the shelves, and we don't have it in India these days. Capsaicin 8% patches, again, we don't have it available in India. And we used to use the high dose Capsaicin cream in people who have postoperative neuralgias in my training overseas. But on many occasions, you have to give them a general anesthetic just for them to tolerate those high dose capsaicin patches. And then you have the third line Botox injection, which is mainly for peripheral neuropathic pain, and the strong opioids, again, as a third line. So, I mean, the opioids have been in and out of the neuropathic pain thing. Previously, it was used to treat all pains, including neuropathic pains, and then they said, no, you shouldn't be using opioids for neuropathic pain. I think these days it has come back again, particularly oxycodone. I think there is a lot of research suggesting that it's quite useful as a third-line drug in treating neuropathic pain. So next slide, please. Next. Yeah. So we have the NUPSIC guidelines, and these are all the inconclusive recommendations. Now, the combination therapy. Now, the thing is, we very is a combination of antidepressant with an anticonvulsant. When we say inconclusive recommendation, it just doesn't mean that there are a lot of studies to support it. But clinically, we all know that it is the combination therapy which works quite well. Combining a gabapentin or a pregabalin with amitriptyline or duloxetine, which works much better than just using a single drug alone. Again, for the capsaicin cream against the patch. Carbamazepine. Now, the thing is, you would like to think that carbamazepine is a wonderful drug for neuralgia because a lot of patients benefit from it. But it has been used for such a long time that people haven't done proper RCTs to kind of say definitely that this works. And that's the reason why carbamazepine has ended up in the list, though we know that it's a very, very effective drug in trigeminal neuralgia. And then there's a long list, clonidine, the lacosamide, the lamotrigine, NMDA antagonists like ketamine, oxcarbazepine, the SSRI. The SSRI used to be very fashionable when I was in training, to start someone on fluoxetine, and things like that. But they have an NNT of 14, which means you have to treat 14 patients for one of them to get some benefit out of it, which means it's as good as the beta errors, what they call the 5% sort of errors. So it might as well be by chance rather than true effectiveness of SSRI. So SSRIs are out. The SNRIs, which are going to be much more useful. And same with the tapentadol, which is the new kid in the market, topiramate and zonisamide. Now, these drugs in the middle, the conclusive recommendations are not saying that it doesn't work. It's just that there are not sufficient studies to back up our sort of prescription. And then there are certain weak recommendations against use that, they're pretty useless, which is cannabinoids and valproate. Now, cannabinoids is a very touchy subject, not in India, but in US. I think there are about 30 states which have legalized medical cannabis, and a lot of studies suggesting that it's quite useful in the neuropathic pain with multiple sclerosis and things like that. So that weak recommendation against use might change maybe in a few years' time. And there's a strong recommendation against use. That's just, please don't use it. So that is levetiracetam and mexility. Now, this is strange because we used to use mexility when we were in training. So what we used to do is to give them a lidocaine infusion as test dose, and if they do respond to the lidocaine injections, which is, lidocaine basically a sodium channel blocker, then you convert them into oral mexilitine. And this was all the big rage when we were in training. But 5-10 years later, you find that it's people saying that it's not only useless, but it could actually do harm. That's what it means, actually. Strong recommendation against use. So next slide, please. So these slides is just kind of taking a different look at the quality of evidence, the effect size, and the tolerability of the first-line drugs. Now you can see that the SNRIs, the TCAs, the pregabalin, gabapentin, they're useful in all neuropathic conditions, not just the peripheral neuropathies, but also central neuropathic pain conditions. Now, they might not be as effective in post-stroke neuropathic pain compared with painful diabetic neuropathy, but it's still kind of a useful thing. And you could see that they're all sort of reasonably tolerated, and they have a decent safety profile. And the quality of evidence for SNRI is high. The pregabalins are high. I think the TCAs are moderate, mainly because I think no one is interested in doing trials with it anymore because there's not much money involved. The TCAs are very, very old, actually, the amitriptyline. Okay, so next slide, please. So these are the second-line drugs, again, looking at the quality of evidence. You can see the capsaicin 8 patches have as a very high quality of evidence in peripheral neuropathic pain conditions, and same with the lidocaine patches as well. It's a shame because it's quite useful in a certain subgroup of post-traumatic neuralgia, particularly they have this deafferented subgroup, and they have this a subgroup where there's a lot of peripheral nerve damage. So I think it's quite useful, but it's not available. Maybe it might make a comeback, and we might get lucky with that. Tramadol, it's got moderate quality of evidence, and it could be used in all neuropathic pain conditions, both peripheral, central, and whatnot. Next slide, please. And that's the third-line drugs, which is strong opioids and Botox. Now, when you talk about strong opioids, all research in opioids, or most research in opioids, has been with oxycodone, and it is not available in our country. And it seems to be effective in all neuropathic pain conditions, the peripheral as well as the central neuropathic pain conditions. And again, it's got a decent, the tolerability and safety profile. And same with the Botox. Botox is mainly used for peripheral neuropathic pain conditions. Now, this is something which I don't have much experience in, sort of injecting Botox for peripheral neuropathic pain, but it seems to be consistently the third-line drug in many sort of guidelines, the AFNS guidelines or the NUPSIC guidelines. It seems to have a place there. So it's something we can think about. Pretty expensive again. I think an ampule of about 100 units costs some 8,000 rupees. So it's an expensive business, and it doesn't, it's not something which works for too long either. It works for a few months, and then probably you have to inject Botox again. So next slide, please. And that's the recent NUPSIC guideline, which is the IASP's special interest group, which we kind of looked at it earlier. And this is what I was trying to say. The gabapentin, depending on which country you live, the Europeans think 2,700 milligrams is a fantastic dose to use, whereas the Americans think it's 3,600 milligrams. So I think the upper limit of the dose seems to vary with the gabapentin. And same with the pregabalin seems pretty standard, 300 to 600 milligrams. But very often, particularly in India, you give them 75 milligrams of pregabalin to be taken at nighttime, and that one capsule knocks them off for a couple of days, actually. We're quite sensitive, South Asians, to these medications, so it needs to be titrated very, very gently. And I think India is perhaps the only country where they have a 100 milligram gabapentin and a 50 milligram pregabalin. I think they also have a 25 milligram pregabalin, if I remember right. So I think it's kind of trying to tailor to the local needs. The SNRIs, the duloxetine and venlafaxine. The duloxetine seems to be the flavor of the month. It's very widely used, and it's got it has been received very well, particularly among the neurologists. Every alternate patient whom we see in the pain clinic is on duloxetine these days, and it's got very good evidence in peripheral neuropathic pain. Not fantastic, but something to hold on to when it comes to 20 milligrams twice a day, and seems like it can go up to 60 milligrams twice a day. It's the kind of dose which I've rarely used. And venlafaxine too, there is a certain 150 milligrams once a day or 225 milligrams once a day. We use it in twice a day dose, actually, duloxetine. And the tricyclics, we are all sort of well experienced. We start at 10 milligrams, but the guidelines say that you should start at 25 and maybe try to get up to 150 milligrams once a day, or in 2 divided doses. Okay, next slide, please. So just a very quick one, a couple of minutes. We'll go through the other sort of biological treatments. Apart from that, you can do what's called the stellate ganglion injection, particularly when it comes to conditions like complex regional pain syndromes. Next one, please. I don't want to spend too much time in these. The intercostal nerve blocks, particularly for intercostal nerve pain, when someone's got breast cancer or someone with lung cancer with rib mets, it seems it's quite a useful sort of procedure to do the intercostal nerve block, or even for peripheral, post-herpetic neuralgia and things like that. Next slide, please. Cervical epidurals, when there is a disc pressing on the nerve, the sharp shooting pains going down the arm. The normal history is you leave it alone, don't do anything, even not even the symptoms settle down after 2 to 3 months. But if it's too painful, then it's too painful, and sometimes the medications takes a long time to work, then you can give it a go with the cervical epidural. Next slide, please. Spironolactone, particularly for atypical facial pains, cluster headaches, that sort of things. Just kind of injecting into that inverted flower vase shaped sort of appearance. Next slide, please. Next slide is about the Gazerian ganglion, trigeminal neuralgia. And it seemed to work quite well in a lot of patients. This is interventions of at least 90% of them respond quite well to these Gazerian ganglion RF ablations, or you can inflate a balloon in there. So a lot of things you could do. And previously, people used to inject glycerol. I think it's slightly gone out of fashion these days. Next slide, please. Transforaminals, particularly for lumbar, sort of sciatica, neuropathic pain. Next slide, please. Intrathecal pumps, it's quite useful. I think there are a lot of drug medications which could be used in the intrathecal pump. A pretty expensive business when it comes to India. It costs around 4 to 5 lakhs to get a pump inserted. And the thing is, people use different combinations. They use bupivacaine. They use a combination of bupivacaine with clonidine. They use bupivacaine with clonidine with something else. They call this the polyanalytic consensus conference, but it is not something which is used specifically with neuropathic pain. I think the neurosurgeons use it much more for treating spasticity, where they put in baclofen inside the pump. So next slide, please. The next slide is about the spinal cord stimulators. Again, a pretty expensive business, but there are a lot of advances, recent advances in spinal cord stimulation. Maybe it's one of those treatments which might eventually find its place in the treatment of neuropathic pain. Next slide, please. So I think that's about it. And this is a monograph which we prepared for the ISSP. It's quite a lot of work has gone into it. Prof. Saxena from Delhi, so he was heading it. So if you manage to get a copy of that, I think the LCVR people might have it. You can have a look at it. Just looking at the role of tricyclics and its use in chronic neuropathic pain in India. We looked at different kind of neuropathic pain conditions. I think it was released sometime last year, early last year. So you can, if you get a hand of that, I think that should be a quite useful reading for you. Next slide, please. Or I think I'll stop here. This is just the voluntary organization what we're running. We're involved in teaching and training and things. I think mainly the physios and the medical students. The next slide, please. Yeah. And you could that's my Twitter handle. You can look at Pain Free India to have there's a lot of information, and I keep updating it every day. That's about it. So I'll stop there. Thank you very much. I think we can take there's time for questions as well, I think. So yeah, thanks a lot.
Questions. Any questions directed to Dr. Vijayanand they can ask?
Dr. Vijayanand, do you have any experience of using methadone in neuropathic pain?
Methadone in neuropathic pain. Hello.
Yes, we can hear you. Yes.
Hello. Yeah. Methadone in cancer pain, yes, but not specifically in neuropathic pain. I mean, I look at methadone and I look at it and think it is a combination of morphine with ketamine, I mean, NMDA antagonist activity. And I mean, we typically don't use NMDA to treat neuropathic pain, but methadone, I'm pretty sure, I'm saying pretty sure, but it has got a role in cancer pain, but maybe in a few of those neuropathic pain conditions as well. I don't have any personal experience using it in neuropathic pain, but cancer pain, yes.
Thank you. Thank you. I want to ask you, as an experienced pain specialist, you have been in this practice. So I noticed that the NNT of TCA is superior to that of gabapentin and pregabalin in most texts. And still, when you see the list of first-line therapies, TCAs do come as first line, but as the last of the first line. Doesn't that influence clinical choices? Because, is it to do with the cost and the benefit? And does the market influence, the way the physician responds to recommendations?
Yeah, I think the question I think I got 50% of the question, mainly because it's very choppy. The video here is quite choppy. I mean, can I sort of rephrase your question, or can I just check with you if I've understood properly? Is this list of drugs in the first line? They're not necessarily, is it determined by market forces rather than pure sort of science? Is that what you
NNT?
asked?
Yeah. NNT of TCA is in the range of 2s, whereas the NNT of pregabalin and gabapentin in the range of 3 and 4. But still, in most recommendations, you see these as the first 2 in the first line, and TCA is always the last. So it gives an impression as though they are superior. So you think, as when we teach, isn't it our duty to emphasize that TCAs do have a lower NNT and so are, superior in effectiveness?
Yes, certainly. I can understand. I think they probably arranged it alphabetically. That's my excuse, but you're right. I think the tricyclists should be at the top of the list.
If they are truly going,
they have much better evidence.
If they are truly going alphabetically, they should put amitriptyline. It should be first.
Amitriptyline should go right. Yes, you're right. Yeah.
And also, when you mentioned opioids are, not particularly recommended, it came as a third line. But were you meaning purely the non-cancer kind of neuropathies? Because in cancer, the recommendations are a little different.
Okay. Well, most research in neuropathic pain, I mean, just 5 years ago, they said opioids are a no-no in terms of treating neuropathic pain, and we rarely used opioids to treat neuropathic pain. I think a lot of research have come out, and most of the research in neuropathic pain, opioids being effective in neuropathic pain, is through oxycodone, not the other drugs, the morphine or the fentanyl or the methadone maybe, but most of the research is on oxycodone. So I think it's mostly to do with the side effects and maybe better sort of effectiveness profile of other drugs compared with morphine. I mean, we see that all the time. The patients on high doses of morphine still, when it comes to neuropathic pain, it's not sort of well settled, and you just add a little bit of pregabalin or gabapentin or amitriptyline, they seem to respond much better than just increasing the dose of opioids. In my own practice, I very rarely, particularly in chronic non-cancer conditions, I just stick to the first and second line, and actually I rarely venture into the third line.
Thank you, Dr. Vijay.
Thank you.
Friends, you have a rare opportunity of having Dr. Vijay in front of you. Please ask questions to him.
I have about 133 questions, but I think I'll first see if there are questions from others. Akhil, you have been very silent. Akhil, any questions?
Dr. Iqbal was raising his hand, sir.
Oh, I'm sorry.
Why don't you change this to, can we have the gallery view or something?
We have the gallery view.
Okay. Screen sharing is off.
Dr. Iqbal.
Hello, good afternoon, sir.
Good afternoon.
Vijay sir, I had one question. What kind of drugs are very much useful for neuropathic chemotherapy-induced neuropathic pain, like hands and foot? From what kind of drug will you choose?
Yeah, that's a good question, because a lot of drugs, what I've been sort of rattling up is first line, second line, third line. You will find that they're extremely unhelpful when it comes to chemotherapy-induced neuropathy. Pregabalin is very poorly effective. I think if I would like to choose a drug to treat chemotherapy-induced neuropathic pain, it would be the tricyclics, actually. And same to be said with the HIV neuropathy as well. HIV neuropathy. I think chemotherapy-induced neuropathies, we definitely have to look at a different class of drugs. Maybe, we don't have the answers now. Maybe in a few years' time we have the answers. But it's generally, it's not the kind of drugs we use are not very effective at all, actually.
Thank you, sir.
Thank you.
Are you going to ask a question? Anybody else? Mary? Farzana? Any question? Mary, hi. You have a question?
Mary, unmute.
Yes, I wanted to share. Hi, Vijayanand. That was a lovely talk.
Madam, good afternoon.
Yes. So sometimes there is this mixed kind of pain, right? When you have a neuropathic and a nociceptive component, particularly with cancer or with simple degenerative disc spine. Also, you have a mixed kind of pain. So I just wanted to bring that also into the perspective that sometimes it may not be purely neuropathic, but there can be a nociceptive component also. So that also has to be kept in mind.
Yes, ma'am. I fully agree with you.
Farzana? Any question or comment? Thakur Pukur team?
Yes, sir. Good afternoon, sir.
Thank you, Dr. Vijay. It was a wonderful talk. Actually, I wanted to make sure that in palliative care, most of the books and most of the teachings we have yet they actually advise us to use gabapentin or pregabalin or this type of drugs. Or you have.
I think, sorry, it's getting stuck actually. The videos.
Farzana, why don't you switch off the video and talk? The audio may be clearer.
Okay.
Yeah.
Can you hear me now?
Yes, we can hear you well now. Yes.
Thank you for your nice presentation. Actually, my question is Nandini, in palliative care, we are advised to use for cancer patients neuropathic pain, opioids plus any other gabapentin or any other drugs. So should we do that, or we should try gabapentin first, gabapentin or pregabalin or this type of first-line drugs, and then try opioids? I'm confused over that. Thank you.
Can I answer that question? Yeah. Yeah, I think in cancer we rarely get it's a pure sort of. I think pain. It's going to be a mix of things. You know, it's always going to be associated with neuropathic. Unlike chronic non-malignant pains, where you have a pure neuropathic pain conditions, it's, you know, when there is an infiltration, it involves the bone and the nerves and the muscle as well. So, maybe, you know, in cancer pain is different to what we you know, talk about as neuropathic pain, where opioids have a role to be started with before we, or in conjunction with, or before even the other sort of neuropathic pain medications. Whereas if you look at non-malignant pains, it is slightly different actually. And these guidelines are basically for non-malignant pains, but you know, the cancer pain doesn't really sort of come with a single label. It's usually there is bone pain, there is visceral pain, there is nerve pain, and they all have different mechanisms. And we used to have use a combination of drugs and different drugs to deal with it. I think opioids probably are the first line, of, particularly in severe cancer pain, even before we start thinking in terms of gabapentin and pregabalin.
Thank you, Dr. Iqbal and Rajashri have questions.
Hello, sir. Hello.
Hello.
Hello, sir. I have another question, sir. Very difficult. We had a patient with paraplegia, sir. That is, there was some metastasis in the T4, T5 vertebra, and there was there was no paraparesis basically. So she was complaining of severe pain. In spite of paraplegia, he was complaining of severe pain in the lower limb. And we tried to give many of the neuropathic, started from the imipramine, gabapentin in highest doses. And also we gave, even tried to block this, give a spinal anesthesia to the block the pain, but all failed, you know. And one day, that person, you know, took a blade, you know, and he just cut the whole abdomen, you know. So it was just type of, you know, we asked him, then it has to be repaired again, you know. We took him to the OT. Then it was luckily not up to the peritoneum, the teacher. Then we asked him, why you cut your belly? He told me that, sir, I was trying to find pain inside my stomach, so I cut my abdomen. So it was very, very distressing for us. So just my question is that whether there are any algorithm to manage such kind of central neuropathic pain.
Yeah. It's again a tough one, the central neuropathic pain, particularly when there is spinal cord injury. You have the at-level pain where the nerves are crushed, and you have this kind of like a grid, like kind of something, a vice gripping around the trunk. And you have the above level pains, which is the usual pains what you would get, you know, the shoulder osteoarthritis, the neck pains and whatnot. And you're talking about the below level pains, which is the dysesthesias. It's extremely unpleasant, very painful conditions. And there are a dozen mechanisms why, you know, such pain should happen, and such pain should be maintained. And generally speaking, these neuropathic pain medications, what we're talking about, it's got the NNTs are quite high for the treatment of spinal cord injury pain. Now the thing is, there are studies looking at motor cortex stimulation and intraventricular opioids, you know, directly dealing with the periaqueductal gray, which showed some promising results. But it's more sort of advanced techniques, you know, which I know very little about or exposure to. But in terms of medications, unfortunately, that's all we have left, actually. I think sometimes we need to accept that, you know, we can't do much for certain patients, you know, more of a maybe psychosocial sort of things. But as you mentioned, it's very distressing, not just for the patient, but also for the physician who's looking after him, if he starts sort of, you know, self-inflict injuries and things like that. But yeah, I agree. I think it's more like targeting the brain, which is going to be helpful in these conditions.
Thank you, sir.
Thank you.
Dr. Raji, you wanted to ask something? And this will be the last question. Thank you.
Thank you, Vidya. Yeah, I hope you will give me a chance to say just two things very important.
Can I?
Yes, of course, sir.
Sir, you mentioned there is weak recommendation for sodium valproate for using it against neuropathic pain, and there is strong recommendation for mexilectin and levetiracetam for use against neuropathic pain. Could you mention why? Because the same category, same class of drugs like pregabalin and gabapentin being anticonvulsants, they can be used, but there is weak recommendation for sodium valproate, which is again an anticonvulsant. The same for levetiracetam. So what is it?
The thing is, sure. Though it is a broad group anticonvulsant, if you look at the mechanism of action, it's quite different. If you look at pregabalin and gabapentin, it works on the calcium channel, the alpha to delta calcium channels. Whereas if you look at all the other anticonvulsants, they work on the sodium channels. Obviously the sodium channel blockade is not as useful as calcium channel blockade is what we can make it. The other way of looking at it, these are all old drugs and no one is interested. These are often drugs that they don't want to do research. There's not much money to be made, so they don't make up to the list. So you could interpret it either way, but there is a mechanism-based sort of idea to it, because both the anticonvulsants are calcium channel blockers, whereas the usual anticonvulsants like the carbamazepine, the phenytoin, sodium valproate, they're also the sodium channel blockers.
So the same applies to mexilectin as well, because lidocaine and mexilectin, they fall in the same category.
They are sodium channel blockers. And the thing is, when I talked about my own experience, it's just trying to extrapolate certain injections and responses to injections. And because you can't keep injecting lidocaine every day, so you have to give them lidocaine as a tablet, and the closest tablet we have to lidocaine is mexilectin. But unfortunately, it's got a lot of side. We used to use I think the dose is 50 milligrams 3 times a day. That's the dose we used to use. This is not long ago. This is 2008, 2007. But it says that there's a strong recommendation against use. I haven't come across mexilectin in India. I don't know. Maybe the cardiologists have access to it to treat arrhythmias, but I haven't seen mexilectin in India.
We had used it, sir. We had used it for a couple of patients, so that's why I raised the question.
Oh, you've used it. Okay, so obviously there is there. But yes, the NNT is pretty long, particularly for the SSRIs and the mexilectin. So that's the reason why people ask not to use it, or maybe it's because the arrhythmic potential with the mexilectin.
Thank you, sir. Thank you.
Sir, please ask your question or summarize some of the points that you would like to let us know, sir.
That list also include flecainide by any chance? The anti-arrhythmic flecainide. Because when in the occasional patient with the intractable neuropathic pain, where we find that lignocaine works, then a sustained oral medication is necessary, and the only 2 drugs available were mexilectin and flecainide. Now, Rajesh, to the best of my knowledge, in the last couple of years, mexilectin has gone out of the market anyway. Flecainide is still available, and we have been using it. That is not featured that list. I am not saying that it's for everybody. It's once a year that we may have occasion to use it. But I'll repeat, intractable neuropathic pain responding to intravenous lignocaine, then oral flecainide may be a choice. Any comments, Vijay? I mean, any objections?
No, I don't have any comments, and I think it's well worth it. I mean, neuropathic pain invariably, like the one Dr. Iqbal was mentioning, if it's refractory to all treatment and it's distressing, after a while it kind of distresses out us as well. Actually, you want to throw the kitchen sink at it and see if you can treat it. I think flecainide, though it's not on the list, I think I would certainly be tempted to give it a try if nothing else works. Yes.
And generally, your talk was mostly concentrated on, I mean, for all practical purposes, on non-cancer neuropathic pain. I'm just making sure that everybody understands this. Because when it comes to cancer pain, as Mary said, because it's a combination and because the duration of therapy is usually time limited, we tend to use opioids more. Now, there are recent recommendations against using opioids as a first or second line medication in non-cancer neuropathic pain. Repeat. Opioids are no longer, it's not a combination. In non-cancer neuropathic pain, opioids would only be a third choice, purely for fear of, over a very prolonged period of time, what will happen. The dependence issue is a fear. If we know in cancer neuropathic pain, we are using opioids. In step 2, tramadol is an obvious choice, and in step 3, methadone is an obvious choice, because these are two opioids which have an additional mechanism of action which helps in neuropathic pain. Oxycodone comes into neuropathic pain scene mainly, I think I feel pretty sure about it, only because of the very strong arm measures and marketing undertaken by US industry during the last 15 years, where everybody was loaded with oxycodone. So it may come to India soon, and a word of caution. Just as gabapentin and pregabalin got up on the list of first-line medicines for no rational reason, with an NNT lower than tricyclic, they managed to stay up. So word of caution in our poor country, remembering that they are marketing laughably low strengths of gabapentin, 50 milligrams. Pregabalin, etc., which are known not to be effective, are tried, and the obvious effect is financial destruction of the family. Vijay, I would like, you have so much of experience, I would like this opinion. Now, sometimes combination of neuropathic drugs are used. If one alone fails, a combination of a tricyclic and an anticonvulsant might be tried. But generally, the thing that we have been teaching here is that the dose of one should be optimized before you bring in another. That is, giving 12.5 tricyclic and bringing in 50 milligrams of pregabalin seems to be irrational. Do you have any comment about that?
I think the combination therapy has its obvious advantages. If say for instance I start someone on gabapentin, the reason why I would like to add a second drug is it's not as as I would like it to be. Say for instance, pain reduction is only 20-50% as opposed to my goal or the patient's goal of having a 50% reduction in pain, or they start getting side effects at a higher dose where you want to combine it with a different drug where those side effects might be. Let's say for instance at 900 milligrams of gabapentin a day, if the patient gets side effects, then I would like to stop at 600 and then maybe add a duloxetine or an amitriptyline to treat. So it is determined both by the efficacy of the drug as well as the side effects of my choice of the first drug which I use for neuropathic pain.
And Vidya, I promise to stop with this sentence.
Yes, sir. Everybody noticed that the NNT for the Western was still 2. Whatever we do for some neuropathic pains, pain relief is sure to be inadequate. There will be a huge number of patients who will not get relief with the pain. I think we need to be honest with them. When we keep on trying one desperate thing after another and interventions, then their life becomes even more miserable. And our management has to include the strategy for helping them to live with the pain. Maybe that will have to be another session in itself. How do you help people to live with a pain that we are unable to relieve satisfactorily? Thank you.
Yeah. Thank you, sir. Thank you.
Thank you so much, Dr. Vijayanand, for taking out time for us today,
You're welcome.
this afternoon. we hope to have you back another session, which is relevant to your field of
Thank you.
specialty.
Yeah,
Thank
sure,
you so
sure.
much.
Yeah.
Vidya, please take over.
Thank you.
Now, can we move on to Dr. Iqbal's case presentation? Dr. Iqbal, are you ready to go?
Yes, madam.
Yeah, we'll start.
At the very outset, I would like to thank EcoPelim India for giving me the opportunity to present my case. This is a very small case. Can you have the next slide? This is a man, XXY, is a 40-year-old. He came with CA base of tongue 3 years back. He received all the cancer-directed treatment, that is, he received chemotherapy as well as he's completed the radiotherapy. Also, after the completion of chemo-RT, he had undergone radical neck dissection bilaterally. Now he has recurrence in the neck. Now he came to our palliative care ward with very increasing difficulty in breathing. Very much he was breathing, difficulty in breathing, and he had moderate pain in the neck, about 5/10, and he appeared to be very, very uncomfortable. And he was telling that he was choking, that as I'm sinking, I'm choking, and also he had great difficulty in swallowing. Next slide, please. Now on examination, we could found that he had very obvious upper airway obstruction with inspiratory as well as expiratory stridor, and also he was using his accessory muscles of respiration. The saturation was near about 94, 96, and there was bilateral hard neck nodes with mild tenderness. And the surgeon, we consulted our surgical oncologist so that he should go some tracheostomy, but of course he refuses to undergo any tracheostomy. So since he refused tracheostomy, I thought that it was the only hope to relieve his stridor, but he was very much vehement that whatever happens to me, I don't like to be done a tracheostomy. So he was already on oral morphine, 10 milligram Q4H, and now SOS. And also we have started IV morphine because he was not able to swallow nicely. And also we have added some dexamethasone in the hope that it will reduce some kind of edema. And also he is getting paracetamol QID and little bit of oxygen therapy. Now regarding the psychosocial and spiritual issues, he is about 40-year-old man, very, very poor social support, no financial support, but he believes in Almighty, that he had a strong belief in Almighty, very religious man, but no relatives comes to visit him. He is aware of the diagnosis and prognosis, and he wants to die. He tells me that to make him comfortable, he wants to die. He wants to give something that he should die very promptly without any suffering. Next slide, please. So he is a daily wage laborer, and he was working in a tea garden. It was not a permanent, he was not a permanent employee. He is a divorcee with 3 children who are now staying with his mother. And also mother, nobody is there at home basically. Even the brothers are also not coming. They just came, somebody came and dumped the patient to the hospital, and we rang every member of the family, but nobody is responding. They're not responding at all. Next slide, please. Now, my questions are here, we thought that we set together all the palliative care team, we had difficult time in managing the patient, and our questions were, should any other medication be added at that point of time? What should you plan to do if he has sudden worsening of the obstruction? Suppose, what should you do? And what should you tell him now? I asked my nurses that whether we should tell him that you are dying. They are afraid, sir. They are afraid to tell. Sir, how will you tell him that you are dying? It is a very, very dreadful thing to do. And how to deal with the situation if nobody comes to receive his body. So these are my questions. I think I'll be very much happy if these are being discussed. Thank you very much.
Thank you, Iqbal. Anyone wants to answer the questions? Farzana, you want to say something?
Iqbal, for ease of discussion, why don't you put in one question at a time? You have listed the questions, but now we'll start with one of them.
So,
and then we will proceed. Just for us, the first one.
So the first question are that whether, because the patient has refused tracheostomy and we know that he was having a stridor because of the compression in the neck. So the first question is that whether any other drugs are there which could relieve his obstruction or any the symptoms, because the pain was mild, we are controlling with the morphine, and his main problem is now stridor. Whether there is any other drugs, whether it could help him in relieving the stridor. Should we increase the dose of the dexamethasone?
So the reframing of that question is the optimizing of his feeling of breathlessness and the stridor. What else may be done to optimize it currently as the way it is?
Exactly.
So who would like to begin the discussion on that point? Please go
ahead. I'm John Ely from University of Minnesota in the U.S., and I've spent some time at Pallium. Two things crossed my mind as places to start. One of them, I wonder about any potential role of inhaled bronchodilator or inhaled anticholinergic agent, just for a trial to see if that makes any difference in his stridor or comfort. And I think that would be something that you could try, and you might know within several trials what the benefit would be. And I think framing the conversation for him, that is explaining that this is a trial to see what effect it has, would help him be able to respond appropriately. If I'm recalling correctly from your presentation, you're already using steroids.
The audio has got cut off, I think.
Any swell loss contributed to this. Another thing that crosses my mind is, would there be a role focused on his for him? I feel that can you hear me? Can you hear me?
We can hear you.
Intermittently, we lose you.
Okay. But I wonder about the role of benzodiazepine for anxiety related to his stridor, and I felt like I heard embedded in. I haven't seen him, but I feel may there be some anxiety that could be relieved with that also. Those are my initial thoughts.
Thank you, Dr. John. Mary wanted to. So Dr. John mentioned about reversibility, reversible aspects, whether it has been looked into. Is there any contribution? Of course, you mentioned stridor, which indicates the upper airway. But if there is a contribution of the lower airway, bronchodilation, etc., and the management of anxiety, that is one thing that he has suggested. Mary wanted to say something.
Yeah, I do agree that some nebulization or something could help. And then optimizing his position, keep him head and up position, that will ease his breathing, because obviously there is a mechanical obstruction, and tracheostomy is the only way out. But the other ways of trying to do the non-pharmacological ways, like head and up and giving him a lot of nebulization, maybe that will ease it. And then I was wondering about the role of morphine in this kind of thing. I don't know whether that would be a thing, but something to, maybe it would, I don't know, I'm not sure about that, but I would like that to be discussed also. And
so
oxygen,
Iqbal,
of course.
okay. Iqbal, you have mentioned morphine IV SOS. I understand that 10 milligrams was started for his pain, is it? And what is the meaning of SOS IV morphine? Could you explain to us?
It is a breakthrough dose basically. If he complains actually we use morphine initially for relieving his pain basically. So we thought that if he complains of pain again, it is for relieving breakthrough pain. We advise because whenever because we go away and if there is some pain, the sister inject morphine IV in between because it is the drug which will act very quickly because we don't have any fentanyl lotion, something like that, which will act very quickly. So it is an SOS, we write like something like that, 10 milligram oral if it is available. In between, he gets 3 milligram IV SOS. This is to relieve his pain. But I was wondering, to relieve breathlessness, we know that we use low dose of morphine. Generally, we use low dose of morphine, 5 milligram orally or 1.5 to 4 milligram orally. So we are anxious whether to increase the dose of the morphine because the pain relief is okay. If you increase the dose of the patient will ultimately be sedated and he may die. And the family members, nobody is here, somebody has come and we don't want that the patient should die very quickly. We at least want that he should remain for some time, we should communicate with the family by some time, so for this reason, basically.
So as of now, the morphine is going on for his pain relief. And generally, it must be familiar to everyone that if we are already having, say, for example, 10 mg of morphine given for pain, and there is something to be added for breathlessness, it is usually 25% of the ongoing dose is added to it. So 10 becomes 12.5. So that is how we add on the breathlessness component to the dose of morphine. So that is one way. Here the question is, what are the contributors to his breathlessness, which we are looking at optimizing? So one is actually the mass you have mentioned. Now the reason for his breathlessness, is it from how much of it is left in the base of the tongue? How much of it is due to the compression on the, part above the, wherever you can do tracheostomy? If the obstruction is above it, how much of it is going to be relieved by a tracheostomy, right? Because if the tract below tracheostomy is patent anyway, and that is not contributing, what are we contributing by doing a tracheostomy? That's that anatomical location of obstruction, if it is due to the tumor in the neck, is very important. I think that is something. Nebulization, Mary has mentioned. There are many more points for optimizing, I guess. So I can see Jennifer has raised hands. Please go ahead, Jennifer. Unable to hear you, Jennifer.
Not it. We are not able to hear you.
Have you unmuted yourself?
It is on unmute. But
We can't hear you, Jennifer. Vidya, while they are working on it, is there any other raised hands?
as of now, no, ma'am. Sir, you have to unmute. Sir, you have to unmute.
Thank you. Am I okay now? I would want 2 minutes at the end, but I think first Sunil will have something to say.
Regarding the optimization, I think 2 or 3 things can be done. One is, as Dr. Nandali told, the dose of morphine can be increased. And another thing is, I'm not very sure, but the steroid increasing the dosage may have some effect if it is due to compression. And third thing is if there is a component of anxiety, then benzodiazepines should have a role. So these are the three things that we can try in these patients. That's regarding optimization of drugs.
Jennifer, how are you? Can you just check the audio now? So while she's working at it, I think there is one more reversible component we need to look at, that is infection, presence of infection. If there is any suggestion, we need to make sure that it is adequately handled. And dexamethasone, I see that you're using 4 milligrams. Probably there is scope for definitely going up on the dosage. So about optimizing all this is going. Jennifer is not yet in. Okay, we will take the question, comment from them later. We'll go on to your next question on the case. So we are looking at the reversible components and treating them. And also, if the tumor is above the place where we have access to tracheostomy, there is no point in doing or convincing for tracheostomy. So if it is base of the tongue obstruction, maybe some nasopharyngeal airway, if it can work, or as Mary said, propped up position, or sleeping on little more semi-prone position, etc., where the tumor will fall away from the airway, may be more helpful than doing a tracheostomy. So we need to really understand that. What is your second part of the question?
Can I forgot my second question. The slides, can you have the slides, please?
Iqbal, you were wondering what to do with the body, honestly. Eventually, when he dies, that was your concern. You didn't word it that way, but that was it. It is an important issue. I mean, it is certainly a very important issue.
You asked what should we tell him.
Yeah. Now, thing is that my second question was that how to comfort him verbally. What should I tell him? Whether he's dying now. Basically, I will not tell him. Basically, I cannot tell somebody that you are dying. I feel difficult for myself. It was the question raised by my nursing team, basically. So they asked me that if she's dying, what to tell him. He's aware. He does not have any other systemic disease. Only he has obstruction. So he's alert and conscious. So if something happen, if there is sudden onset of obstruction, what should we tell him now? Whether we'll tell him straightway that you are dying, or any other thing which can comfort his mind, because we know that if he dies with sedation, it will not cause him any harm. But should there be some way to tell him, because nobody, family member is there around, a good way of telling that you are dying, we are not able to do anything, something like that. Any good words are there? How could have comforted him?
Iqbal, I want to answer your question, and then I want Sprati to comment. Iqbal, I am distressed by putting myself in the patient's shoes. You could be my doctor. I am having an upper airway obstruction. It is very clear. It's very clear that that's causing an upper airway obstruction, and I am choking. Certainly, I'm glad you are trying to optimize my condition by hiking a little bit of the steroid and maybe looking for other correctable factors. You must, but it is still very unlikely that I am going to improve. Ordinarily, if I am already on pain, you would increase my morphine dose by 50% if I am also breathless. That's what you would ordinarily do. Go from 10 to 15. But in spite of all that, I don't want my neck to be punctured, and you have to respect that. I want to go in one piece. You could have done something early enough, warned me about it, taught me slow, easy breathing, but it's too late now. At this point, when I am choking, you can't. When you breathe slowly in and out, when you have learned to do that, obstruction is less because the negative pressure from inside becomes less. But that is too late now. If you said tracheostomy is the only way out. No, you can help me to die with as much comfort as possible. I think we have to confront that. I'm going to make some of you uncomfortable by bringing in palliative sedation. If you cannot relieve my obstruction, I don't want a tracheostomy. Then you have, after you have optimized the medications, at some point you will have to confront this. You may have no choice except to give me palliative sedation. You are increasing the dose of morphine a little bit. Sunil mentioned benzodiazepine, but I don't mean 5 milligrams of diazepam or 1 milligram chlorazepam. Whatever agent you use, you may have to sedate me enough so that I am not suffering anymore, knowing fully well that that may hasten my death. But you are looking at my quality of life. You said you don't want him to die now. Why not? You must ask yourself. You are afraid. That's why you don't want him to die now. He's going to die in the next few days anyway. You want it. You want time because you don't know what to do. We'll have to face it somehow. That person has to be helped to die well. About communication, I think that's too much to go into now. But certainly ask him, how do you feel? Are you afraid? What are you afraid of? He'll say, I am going to choke to death. And pick up that opportunity. Say that, are you worried only about choking or are you worried about death? Most of the time they'll bring up the word, and if we grab the opportunity, that will give you an opening. Because right at the moment, you are afraid to bring up the word yourself. But at some point, you will gain the courage to ask them, what do you think is happening to you? Are you thinking about death? Sometimes it will be necessary. Here is a man who has been rejected by the whole family. I'm glad you are trying to contact the family. But even if no one comes and he has been so rejected, I hope he'll go feeling that you care for him. That will be important for him. The feeling that somebody cares for me. And I think you should inform the police. That's what we have done in this hospital. You must send a letter to the local police station saying that a person is here and his family is not coming anymore. Because tomorrow when death happens, the police may have to get involved because you don't know what to do. Better ask any destitute homes. They will know the procedure. Give an intimation to the police. And when death happens, give another intimation, certify that at the best palliative care that you can give him now to help him to die well and maybe look after his funeral. You might as well get prepared now.
So Dr. Shrikant wants to ask you a question regarding if there is no relative, who will give consent for palliative sedation?
Shrikant, in this case, the man is, it's easier for me to answer your question because the man is conscious. He is able to take decisions for himself. His family has nothing to do with that decision now because they have abandoned him anyway. It is the man's decision. And even if he cannot, he is too sick to sign, you write it down in presence of a witness and both of you write it down. That's important. It's important to document it. Nandini?
Sir, I have, in whatever clinical experience I've had, I've rarely seen patients choking to death, although we keep fearing about it. What has been your experience about actually patients requiring sedation due to choking? Like suppose you see 100 head and neck patients, how many have you seen requiring sedation for choking? And secondly, when do you initiate it exactly? Like what are the different things that you would say, okay, now I must initiate sedation?
Nandini, I'll agree. Most of the time, with your optimization of the medicine, you are able to control the breathlessness adequately. But yes, in upper airway obstruction, the obstruction does become total. Once it becomes near total, the process is much quicker than the edema happens and the obstruction becomes total. So it will have to be done. It's not every day. It's only a rare occurrence, but it happens. Nandini, what was your second question?
What would be the optimal time? Like, when would you say that now I must give sedation? When it is like all the signs of distress, isn't it? Right now, also, Iqbal is giving oxygen. Is it really necessary to give oxygen right now? Because he says saturation is 94%. So please comment on that and the sedation initiative.
I suspect that the oxygen may be actually causing me more discomfort. In an open air room where ventilation is there, it may be easy. But if the saturation is 94, there is still chance of optimizing his condition. Maybe that will work. But if that does not happen, you are asking me now. I am the patient. You ask me, what do you like? Are you so sick that we should sedate you so deeply that you should be asleep? In which case, it is likely that your life may be shortened, possibly by a few hours. What do you want? Ask me. So long as I am in possession of my faculties, ask me. And if I am not in possession of faculties, you are in some difficulty, because then maybe you should have asked me early enough, then I could answer the question. But now it is too late. And if the relatives have abandoned him, maybe you need to document that and certainly inform the police. And if there is no ethics committee, if there is an ethics committee, call an urgent meeting. Help them to help you to take a decision. And better inform the ethics committee well in advance what palliative sedation is. And in the absence of any relative and the patient is unable to give consent, the institutional ethics committee will have to take a decision. If there is no committee in this situation, I don't know whether that's legal and right. I would form an ethics committee now to look at this emergency issue. Mary?
So, when there is an upper airway obstruction, it's quite likely that the carbon dioxide levels will be rising, which itself makes the patient comatose gradually, So I don't know how long he'll be conscious, because CO2 buildup is going to take place, and that itself will start making him feel drowsy. So that's one aspect I thought, he may not be awake for too long if this obstruction persists.
I'll be happy to see you.
So, Iqbal, can we summarize and move on to the next patient?
Sorry. Smriti has something to say, Nandini.
Okay.
Hi. I think Dr. Rajgopal has pretty much covered most of what I wanted to say, but there are two things here. One is medical uncertainty about what is going to happen, and then there is death anxiety that the patient himself is experiencing. What came through to me with the discussions is that clearly this man is isolated, abandoned by himself. He's afraid of choking. He's in a pretty bad way, and his family is nowhere near him. What I also got is that you've said that he wants to die. He's aware of his diagnosis and his prognosis. And then the concern of the team is, how are we going to tell him he's dying? It appears to me that the anxiety in this case and the discomfort is the team's discomfort of how to approach this more than what he's expressed. And when it comes to addressing death anxiety, whether it's the patients or the teams, there are two things, or three things rather, which help both sides. One is clear information. You as a team need to figure out you all have to be on the same page as to what is going on. At this point, like Dr. Rajgopal said, find out what his fears are. Usually the fears distill down to very basic things. He's afraid of choking, maybe one. He's afraid of being lonely, of being alone is another. And at that point, you can reassure him that he's not going to go alone either way. Okay, And by doing that, you are doing him a great service by reassuring him that you are going to accompany him till the end. And finally, that you can assure him of managing various distress symptoms that he's going through. Now, at this point, telling somebody that he's going to die is not, there's a sense that he already knows what's coming. I think it's about reassurance. That's what he's looking for. And that's what I would advise you to give him in clear terms. Okay. I would also suggest stepping up, if it's possible, to get his kids to visit him once. But if that is possible, then very clearly the team has to decide how the children are going to be presented to him. They have to be prepped about what they're going to see. How I don't know what the relationship is. Obviously, I'm assuming that it's not very good. But when you're taking children in to see their father or a sick parent, they have to be prepared in advance of what they are to expect once they enter that room. So you cannot frighten them. So someone has to take charge of that. So I'm just saying, in the event that the family does, agree to visit, that is something you need to think of in advance. And one thing is that I think you mentioned once things escalate, how are we going to have this conversation? The time to have the conversation is now, not wait till when things get bad. So I think just an internal meeting in the team is really important to figure out what your fears are as a team, what your anxieties are as a team, and then work from there. That's what I would have to say.
So, thank you, Smriti. So to summarize very, very briefly, we are going to, Iqbal and team, what the team suggests is that we have to look at optimizing the symptoms, knowing what could be the contributors. So if there is a lower respiratory tract, bronchoconstriction, bronchodilation, nebulizations, upscale the morphine dose by 25 to 50% to add on to the treatment of the dyspnea component. Maybe you can step up the steroids from 4 milligrams upwards. Look at handling the anxiety part. So in general, optimize the medications. Then if he's still active and the saturation is maintained well and he's reasonably good, you should probably talk to him about slower breathing, as Dr. Rajgopal said. The negative pressure which will close during the inspiratory stridor could be improved during that when he learns that. If it is too late, this is not the time to teach that. And there's need to be a very important conversation with probably not leaving one person to do it. Maybe one or two of you. So many I can see from your team attending this meeting. So together you all can plan and have a conversation with him. The important questions are, what do you think is happening to you? And what are your fears about the situation? And from there, you will get enough clues to move on. Basically, the emphasis being that we are there with you, whatever happens, and we have a few things. And that choking is not extremely common, even though you feel it may happen. It is not the most common thing. But even if there are some issues, there are some possibilities of sedation, and you just have to indicate to us and take the consent. Another thing you have to do is inform the police so that the process has begun and there is no issue about what to do later. And when to sedate will be decided by the patient, so that this conversation will also include that. I think the children's visit again should be guided by the patient. I don't know if he doesn't want at all to see his family. There is no need for us to push the whole agenda. But I think if he has a wish, then we should facilitate it in a guided, controlled manner so that the children are not traumatized by seeing their father in a very strange appearance, and it might cause trauma to them psychologically later. So I think we will send a detailed summary of recommendations. So Vidya, how are we doing on time?
We have actually overshot, but maybe we'll extend the session till 4:30 so that Jennifer can present. Is it okay with everyone?
All those who would like to listen to the second case, please raise your hands. So I think majority want to. Yeah. So please, Jennifer. Is your audio working, Jennifer? Unmute yourself. Hello, Rakesh. Rakesh, are you presenting? Yes. Okay.
No. Gentleman next to me. I'll be present.
Can they hear us?
Can you see the slides?
Can we share the slides?
Can you hear us? Can you
Yes, we can.
We
Yes,
can
we
hear you
can.
very well. Very, very well. Yeah.
Put the slides up now.
Can we share the? Thank you.
I'll be presenting a case that is a 65 years male patient having metastatic neuroendocrine disease. The brief history is backache and occasional upper abdominal pain for 1 month, nausea for 15 days. There was poor oral intake and loss of and constipation for 10 days and no symptom of breathlessness or fever. Next slide. Next slide, please. The family history is, there is nothing significant in family history. The patient was ex-smoker, non-alcoholic. He is an educated person, having 1 son, financially stable, and lives far from the hospital. In the assessment part, there is in general assessment, there was moderate pallor, general condition was poor. On palpation, there was distended abdomen, tenderness in the periumbilical area, there was hepatomegaly, mass felt per abdomen, and there was no ascites. In the investigations part, we had CT scan of abdomen. There was stricture at rectosigmoid junction, multiple hepatic as well, lytic areas in the vertebrae. Ultrasonogram shows hepatomegaly, multiple liver lesions, excessive bowel gastrectomy. In upper GI endoscopy, there is normal and colonoscopy, rectosigmoid junction compressed from outside, no intraluminal growth. Liver as well, FNAC was small round cell tumor. And in liver biopsy, we had metastatic neuroendocrine carcinoma and verified with IAC markers. The primary was unclear, possible primary was gastrointestinal. Our main concern was to manage intestinal obstruction, pain, and surgical opinion for any bypass surgery. And we had psychosocial concerns of the family, worried about condition and prognosis, counseled about approach of palliative care, cost of octreotide, a major concern as well. The cost is high. Treatment for obstruction, we had continuous rice tube suction and IV saline. For abdominal pain, we give antispasmodics, steroids, and weak opioids. There was altered renal function, so fluid management was done. Abdominal distension gradually improved, stool passed, and the pain subsided. And the antispasmodic stopped, and crude kinetics were added. Next, please. There was new symptom on day 4, that is sudden onset, moderately severe melena. PET cell, fresh frozen plasma, and platelet transfusion was done, and the hemoglobin was 8.4 gram per cent, and platelet was 75,000. We gave prokinetic, PPI like 1040 IV BD. We had tranexamic acid, 1 gram IV TDS, short-acting octreotides we have added, 100 microgram TDS, thrice daily for 5 days. Started again after 3 days, and we repeated the dose. We sought the surgical opinion like CT angiography and embolization and repeat upper GI endoscopy with 3C permits. And as there was poor disease, so octreotide infusion only given, no subcutaneous depot octreotide was added. Finally, the bleeding stopped. Next, please. The important issues were bleeding, control of bleeding, to detect source of bleeding, ideal dose of octreotide, any scope of long-acting octreotide. Next one.
So if I understand right, the primary is not yet known. The block in the rectosigmoid junction is due to external pressure somewhere in the lymph nodes or momentum or something like that, right? There is nothing inside the lumen or on the wall. Okay.
We did the biopsy from the liver, and the IHC markers mentioned metastatic neuroendocrine carcinoma, but we don't know whether the primary was the GI or it was somewhere else, the pancreas or any other.
So your primary concern is with Malina, because most of the questions are related to that, and the dose of octreotide. How do you, just to understand the patient better, where do you place the patient in terms of what the, determine the goals of care here? Can we know about the general condition, the functionality, his food intake and activities of daily living, etc.?
Yeah, so if you go performance status wise, the patient was bedridden 24 hours a day. So the patient had a very poor performance status, and if you go by the ECOG scale, it was 4. It was the final stage after which you have death actually. So the GC was very poor, and it was not mandating us to actually do a lot of interventions. It was not easy for us to do interventions. And the approach of care was totally palliative, because the surgeon said that we won't be able to do anything. Neuroendocrine carcinoma, especially if it's a carcinoma, you need to give chemo. It was not fit for any chemotherapy, and radiation definitely will not work. So we were up against a patient who, instead of having a diarrhea, which is common with neuroendocrine GI cancers, was having a constipation, and he was not passing stool for a long time. And then we also had the issue of bleeding. Once the constipation part was taken care of, the intestinal obstruction, subacute, whatever it was, we had this incidence of bleeding. And because he was in such bad shape that we couldn't do the investigations, our main concern was to at least stop the bleeding. Because for any patient family member, if you bleed to death, I mean, it is definitely not excusable in a tertiary care cancer center. So that was a big concern for us. And we did relieve the intestinal obstruction, and then he started bleeding. Then we really didn't know what was the ideal dose, what to manage, how to find out the primary, and also how to find out the point of bleeding.
And
Dr.
the patient,
Vidya Vishwanath, ma'am,
okay,
Dr. Vidya Vishwanath wants to say something.
I'm sorry, but I cannot see all of you, but I just had a word with our medical oncologist after I read up this case. And what they contributed to this was, they said that here you establish whether it's high-grade neuroendocrine or low-grade neuroendocrine. If it's high-grade, then it's chemotherapy, but from the looks of it, probably if it is low-grade, then that is where we use our somatostatin. And what they say is the bleeding is from the tumor. So whatever you do, you're not going to be able to stop the bleeding. Probably the embolization is one way of working with it. And what they say is the LAR sandostatin, that's a long-acting sandostatin, is what would be the option of choice. Now, before you start it, you also need to ask the patient if he is affording for the next 4 or 6 cycles, because just giving him one LAR is not going to really help. So establishing goals of care, finding out whether it's low grade, and then are they in a position to take 4 or 6 LAR is one way of going forward. That's what he says, because the course of treatment goes on after that. After the 12, then the nuclear therapy and various options. So, and for the bleeding, he says whatever you do, the bleeding is from the tumor, so the embolization is what they usually do. So this is the input that I got from the medical oncologist after I spoke to him about it.
Anyone else wants to contribute about what our priorities should be for this patient?
That is a question. Does the patient and family looking for a cure is the question.
No. No.
Okay, Rakesh. So the patients and family, what have they come for? What is their chief question to you? I mean, reason for their visit?
Yeah, so since we are a cancer center, they were initially admitted under the Department of Surgery. And the moment the surgery, so the surgeons saw that it was something which was not possible for them to manage, they immediately transferred us without doing an MDT to palliative care. So the palliative care actually took up the patient from the late night onwards. And fortunately enough, though we have general beds, the family members were with the patient in a cabin. So they were always there with the patient. And we told them that our motive of care would be just to make him comfortable. And because there are a lot of questions from terms of the disease, it would not be actually very easy for us to answer all those questions. But whatever be it, the final situation goes like that symptom control, keeping him comfortable, relieving his obstruction, allowing him to take something orally, making him relatively pain-free. That was our main motive. And they seem to have realized that because they had been in other places before, so patient was not getting any relief. So that was the main thing. We made them understand that.
So Rakesh, you said these are the goals that you have set, but have you had a conversation with the patient and family? Are these also their priorities?
Yeah, so the patient's family members, I mean, the patient was not in a position to talk really in the beginning. Once he had a relief of the obstruction, he started speaking, started eating, and he passed through also. But the son, who was very knowledgeable, educated, he realized one thing, that unless you keep the disease, nothing is going to really work. So his emphasis was mainly on the anti-cancer treatment because it was a cancer which was diagnosed. But we told them that there are situations when you get the diagnosis so late that you really cannot manipulate the disease course. But you can always make him symptomatically well. And if the patient improves and we get a dramatic change, then we can always reconsider certain things. But at this point of time, it is just symptomatic care and making comfort.
I just want to ask, it's been mentioned more than once that about the primary site. I'm just wondering, why is that important at this point?
Yeah, so the primary site, yeah. So I think a question was put up by one of the audience, whether it was a neuroendocrine tumor or a neuroendocrine carcinoma. Because if you go by this differentiation, the tumor grows slowly and you have ample time to treat, and patients have a very long indolent course. And you have the situation where the patient can probably have a next attack after 3 months and you can keep him absolutely well during this intervening period. However, if it's a neuroendocrine carcinoma, it's high grade, and we mentioned it's carcinoma, so it was grade 3, WHO. So there you actually are already out of the box. I mean, you cannot manipulate by keeping and observing for a long time. So this neuroendocrine tumor behaves separately and the carcinoma behaves separately. It's very aggressive. So there is a difference in approach in managing these patients. Regarding the long-acting octreotide, the long-acting octreotide is given once in every 28 days. And it's given in 2 separate doses, 20 or 30. 30 is the recommended one. But it takes a lot of time to act. If he's bleeding right at the beginning, you have to give short-acting. In the same time, you can give a simultaneous long-acting. The long-acting will start working after 7-8 days, but the short-acting will do the trick in the first 5-6 days. You don't have an option of waiting for the long-acting really to work because the patient might be there.
If I understand right, the long-acting octreotides cost quite a bit, right? A few thousand.
Yeah, it is 40 to 50,000 at times, and the Indian generic was not available at that time in Kolkata.
So this is something theoretical. It's not possible for this patient. Is that what we should understand?
Yes.
Mary, you were saying you had a comment and even someone was talking. Vidya, who was it?
I think it was Dr. Raji. She wants to ask the question, in lower GI obstruction, how much can we gain from nasogastric aspiration? What's the question?
So Dr. Rakesh, Dr. Raji's question is, how well did, was it that suck and drip method help? Did it help the patient?
It did. Actually, we were not sure as to what is the level of obstruction. There could have been some higher obstructions also. There could have been multiple levels of obstruction. So when we inserted the Ryle's tube and started sucking it, a lot of material was coming out instantly. So there could have been a higher obstruction. And the lower one, which there was initially thought to be a stricture, it could have been due to something pressing on the rectosigmoid junction, and that did not actually finally matter. So the initial suction saline part really worked well for this patient because the patient started passing stool. But we really don't know whether there was another second or third level of obstruction, because however our main purpose of doing it was served.
How long would you have continued the suck and drip if the patient had not responded?
So if the suction is absolutely negative, you don't get any materials coming out from the Ryle's tube, nothing is accumulating in the bag, then there probably you have sucked the entire material out, and after that the patient was kept on no diet actually. So there is a high chance that you have taken it out, but yet the obstruction is not relieved. So that's when we normally tend to remove the tube.
I'm talking like, suppose the malignant bowel obstruction does not respond to the suck and drip method. What would be if there is something which can correct the obstruction, all this is like for transient measure, this is good. But suppose there is no response and the patient continues to be obstructed and there is no stool coming out, no flatus coming out, what would your conservative treatment be? Because this patient is not for surgery. Patient is, so how long would you continue suck and drip method?
No, in that case, we'll manage it in the mode of malignant bowel obstruction, something which cannot be permanently taken care of. You start giving high-dose steroids. You start giving a bit of painkillers. You give the patient some amount of relief. You have to check the PR. If you see anything, it wasn't there actually, so there was no point in doing a PR because we had already double-checked that. And then you have to give Buscopan, Ioshine. So those are the ones which will actually drive the secretions which are accumulating in the proximal level. That will reduce the distress, there will be less suction. And with the high dose steroids, if the peritumoral edema comes down to an extent, there might be some relief. And once it gets a bit of relief, we can start metoclopramide. We don't give those two together, metoclopramide with Ioshine.
Okay. How about his abdominal pain? You have mentioned patient was given opioids and steroids, etc. What exactly was given and did it help? How is he symptom-wise as of now?
Yeah, so we gave weak opioids. Pain was relieved.
Which one? Which drugs were useful to him? Because he was probably not on oral medication. So what was found useful to him?
Intravenous tramadol.
And as of now, his comfort, like melena, you mentioned, how much melena happened? Was it you were worried that there was continuous loss of blood, or was it like moderate, mild?
No, his vitals were getting jeopardized. The blood pressure was coming down. He was developing hypotension. And he was developing a tachycardia, which wasn't just there before this bleeding. So we thought that the bleeding, it may not be a severe bleeding, but it was actually jeopardizing his vitals. So that's when we decided to intervene.
So now your current situation is patient is doing better, but you still want to solve that if there is this melena continuing, if it comes back, what needs to be done, and what is the role of octreotide. And also we brought in from the group that there is this question of what would be the goals of care in this patient. So from the discussion until now, what would what can help to look at this patient when you get back after this echo? What would you go about depending on the questions that were asked here?
Yeah, so if the patient improves and stays better for some amount of time, not just one day fluctuating health, like one day is good, one day is bad. If for a few days he's better, his vitals are okay, he's taking food orally, he's passing flatus and stool, he's having a moderate amount of picturation, I mean, urine volume is okay, doesn't look dehydrated, he's about to sit up, not having much pain. So that gives an indication that by and large, whatever be the tumor status, is doing slightly better. That's when we can still think of actually explaining to them that this is probably the tip of iceberg. We've just had an episode where he's feeling better. We need to maintain all these medications for some time. If he maintains this for some period of time, then we can think of some other active therapy. And the other concerns like the psychological issues simultaneously needs to be taken care of, which is already being taken care of by the psychologists. We also have the social workers. We are working on the cost of sandostatin LAR, and that is a very easy to use drug. And if you can give that, that really gives a lot of symptom control. So we are trying to approach people who can actually help financially, because these patients, this patient has already spent some amount of money, and we are not being able to keep it absolutely free. So this is what our plan is for the future.
What is the status right now? I'm still not clear. So has he recovered these from these symptoms, or what is his current status?
He's slightly better off. He's slightly better off in terms of pain. He's passing stool. His condition is improved. He's still not able to walk paces and go to the toilet. He still is bedridden most of the time because he's still very weak. His hemoglobin has been corrected to an extent, so are the platelets. Vitals are more or less normal. He's slightly better off. Bleeding has stopped.
Iqbal, you need to say something.
Yeah. Dr. Rakesh, nice to see you. I was wondering, where are you managing the patient, in the palliative care unit or in intensive care unit?
The patient was kept in the cabin, which is not a palliative care exclusive cabin, it's a general cabin, and it is not in the ITU. All this time, the patient was managed in the cabin.
So you as a palliative care physician, you are managing a case of neuroendocrine tumor, isn't it? Neuroendocrine tumor, I believe, Rakesh, these are the tumors which have some response to chemotherapy or syndostatin LAR, isn't it? So why don't you are not clear-cut, very much sure that whether you are offering palliative care. You don't know the line here. You don't know whether the patient is for palliative care or the patient will go for cancer-directed treatment. Now, why don't you manage the patient aggressively in intensive care unit rather than waiting, because you are telling that you need to check the blood pressure, you need to check the input, output, management of the melena, this and that. These are not very much done in palliative care unit, isn't it? We don't do much these things. Patient in palliative care, we don't often check the saturation, the pulse, BP and other things. We are more confined with the comfort of the patient. So what I feel, Dr. Rakesh, I think if you think that the patient needs some aggressive supportive care, he should be transferred to a supportive unit in an intensive care unit, or other physician has to look after him. Then if the patient turns out to be futile, I mean to say that if there is no other resource available, the blood cannot be given, then I think you should take it for palliative care and stop thinking that you will not do any cancer-directed treatment in this patient. I don't know whether I am making any sense.
No, Iqbal, can I say something? Yeah. So, Iqbal, the issue is neuroendocrine carcinomas, if they are metastatic and they are normally by WHO classification, you cannot cure them. Even if you give them chemotherapy, that chemotherapy intent is palliative. It is never said in palliative care chapters that you cannot give chemotherapy with palliative intent in a palliative care patient, because majority of the patients come under palliative care and are getting palliative treatment. As far as kidney and the vitals were concerned, we had a few episodes of bleeding. For that, we didn't monitor him in ICU, because the moment we controlled the bleeding and we gave him some fluid support, everything was okay. Now, if this was a persistent bleeding and we are not being able to stop it, and the patient and the family members are getting impatient and anxious, then I would have thought about it. However, since I'm a medical oncologist also, finally, if I would have transported this patient to an ICU setup, I would have been recalled sooner or later after a couple of days. Can you do anything? So I thought I had the skills of managing it in the routine, and looking at the general condition of the patient, and because patient had metastatic neuroendocrine carcinoma, multiple lesions in the liver, it's just not one single lesion that we have a scope of operating in the future. Multiple lesions in the liver, and having a GI bleeding with a poor GC, the tumor bulk was very high. So when you have a very high bulky tumor, if it's a neuroendocrine tumor, you can manage. If it's a carcinoma, they respond to chemotherapy only if the performance status allows. So I thought that this patient should be managed not very aggressively, very smartly by a group of people. Once he's better, then we can make a statement that look, now he's feeling better. We can think about doing something different for the disease because he's better for a couple of days now. Just 1 or 2 days of remarkable change will not really alter the status. So I accept your point, but I have seen many patients actually suffer by ending up in the ICU, this kind of thing. So I thought it was enough for me to actually handle him in the table.
Dr. Rakesh, from your details, it looks like you are reasonably convinced that this patient should not get fully aggressive care. At the same time, I hear you saying earlier that you have informed the patient and family that as soon as you get a little better, we will do something. So probably they are not in the same page as you are regarding, so the goals of care seems to be very, very vague here. And that is why, there is a hope still with the patient and family that it is just a transient phase and they are not really, ready to handle an eventuality. Even the team, that is probably the team that is working, is not clear where they are heading. So that is an important, I think, clarifications that, with the team meeting, as well as with the meeting with the family, that needs to be clarified so that either way, one needs to have, you said that, the patient is having very poor performance status. Patient's symptoms have marginally improved, but not fully. Patient is still not able to take orally. Even his hemoglobin and details are maintained with, transfusions. Are these sustainable? How much of it, the amount of, cost that is going into maintaining this, is that coming out of, money which should have been better utilized from the justice ethics point of view? So we need to probably answer a few questions here regarding goals very clearly, because otherwise we are not able to clearly discuss this patient. Either we are going in for, blood transfusion, platelet transfusion, patient is going to get up and walk, and then we are going to do something. Or we are going to say no more, because each platelet also costs a lot. I think it is somewhere between 5,000 to 10,000 rupees, each platelet transfusion. FFP's cost. So all this, if it is happening just to maintain some parameters, are we looking at parameters? Are we looking at the patient comfort? So these are some questions that the team really needs to decide, and then only, the actual treatment plan can flow, because we are not able to discuss this in a comprehensive way, because both we are hearing both, maybe we will improve.
Ma'am, we have to close. 1 minute, Dr. Rakesh. We have already overshoot the time and we are already running out of time. In case of octreotide, we'll try to send some recommendations to you as well. And can we finalize and close this session within 5 minutes, please? Thank you.
Maybe I would like some comments from the faculty connected here. Can Sunil and Raji contribute a little bit about this patient too? And Vidya, Vishwanath.
No, Nandini, can I make one final comment before they make a comment? So,
I think you make the comment after these two, so that will be the final. We'll close with that.
So regarding this patient, which Ragesh already told, it's neuroendocrine carcinoma, which is unable to do much. So this patient, I think, should undergo about palliative care. And as octreotide, this patient came with intestinal obstruction. If I was the person who was managing, it would have been in another way without rights to things like that. But as she got good symptom control, and now I think she is not in intestinal obstruction. So this patient can be managed with prokinetics and maybe for continuous pain opioids and steroids maybe in tapering fashion. And for bleeding, we may use tranexamic acid or ethamsulate, which may give some relief if it is not from very large blood vessels. So basically, this is what I would like to do with this patient if he is in palliative.
Thank you, Sunil. Raji, would you like to say a word or two?
Nandini, am I audible? Am I audible?
Yes.
Yes, Raji.
Nandini, I go with Sunil in most of his comments. Like if I were the treating physician, with my experience, I would consider dexamethasone first. So as to find out whether I can overcome the obstruction. And I would give preference to prokinetics than antispasmodics. And if that doesn't work, and if the patient patient goes to have colic, then I would try an antispasmodic. So my first preference would be for the prokinetics. And regarding the IV fluids or subcutaneous fluids and nasogastric aspiration, that will be my last priority. And meantime, I would allow sips of fluids by mouth. Once the obstruction is relieved, I would continue the patient on prokinetics with tapering doses of dexamethasone. And then regarding bleeding, this would be the same like ethamsulate or tranexamic acid. To reduce secretion, rather than trying with octreotide, I would go with either buscopan, hyoscine butyl bromide or glycopyrrolate. This is how I would try to decompress the bowel. Thank you.
Thank you, Raji. And what would be the choice if there is massive bleeding? As Dr. Rakesh said, there was continuous drop of blood pressure and patient was getting dizzy. What would be your approach? Would you give blood and platelets?
And depending on the performance status and the wishes of the patient and the family, if I could communicate them well, I wouldn't try anything aggressive. And without controlling the primary site of bleeding, and if I am not planning for an aggressive management, I will be continuing with a conservative or whatever supportive measures I am doing as of now. And see, in this status, I am not sure what else we can do. Like with such a poor performance status, can we go for any aggressive measures? If that is not possible, then we should be able to explain fairly well to the patient and what are our goals of care, as you have cited well. So if definite treatment is possible, then I wouldn't go for any aggressive measure. I would take it for granted that this is going to be a forerunner of the final event. And I would try to convey my whatever status of my goals of care the best possible way I can.
Dr. Rakesh, you can make your comment.
So, there are two types of referrals we get. One is a patient who has been sent to palliative care in a planned manner. treatment given one by one, patient gradually progressing, becoming palliative, and finally terminal. And there's a separate set of patients who are suddenly transferred to palliative care from another department. So our case was the second one. Now, we had to know what was the communication given by the surgery department to his fellow members. Because you suddenly communicate a statement that this patient is not going to live, it's totally palliative. It's difficult. The other thing is hope is a relative term. I mean, you can always take away hope from a person saying we cannot do anything active, but doesn't mean that you take hope completely away. You can still live a window of opportunity. Our thought was to buy some time, at least do the basics right. If the patient recovers, fine. If the patient does not recover, then there's no point. So I thought, taking a hasty statement, we decided to go a bit slow. Patient improved. Palliative care index, which indicates whether the patient can go for chemo or not, was negative. So this patient was never a candidate for chemotherapy. That's out of the question. So this patient actually needs some only palliative therapy, and we are convinced we are going to go for it. And the patient's family members have agreed that this is what it says right now at this point.
So I understand that you were still not become the primary carer. There were other professionals involved, and the messages could not have been conflicting to the patient and family, and you had to take time out of. So have you? I think one of the important tasks would be to complete the, have sort of goals of care communicated amongst the team members who are looking after this patient. If there is another oncologist involved, etc., that meeting is probably a high priority, and then there is one single language spoken to the patient, because if they say something and you say something, there will be conflict. So an important priority would be to have team meeting with the team that has referred and who are still communicating with the patient, and then have this detailed communication, because I think you in your mind is reasonably convinced that this patient should get aggressive comfort care and not aggressive interventional care. So before that, this one step is important. Then after that, and because all this is finally costing the patient, whatever we are prescribing in terms of, inconvenience for us is costing, it is coming from the pocket of the patient. And that is again going from the mouth of the family and from the school fees of the children. So we need to be very mindful about this, sort of crucial, sudden expense that is occurring in the name of cure and treatment, because that is what they are thinking. Ultimately, he will walk back home. So it is our responsibility to bridge these gaps in communication. Thank you, everyone. Vidya, sorry. I hope this is a little more logical than, a few minutes earlier, because this discussion was a little different. Vidya just closed.
I know. No, it has been a good discussion. It's just we thought 4 o'clock, and it's like a usual timing. That was the only worry I had. But it was a very good discussion and useful session for everyone. We'll send the recommendations and summary in a day or two. Anything specific, if you want to ask, kindly send it to us and we will email. Yes, ma'am. Yes, ma'am.
I have one more thing to mention. That is, the next topic is on opioid access, and Vidya has all sent you certain forms. Please fill them, because it's so important to hear from you the issues that you're facing at your institution, so that the discussion will be only on the difficulties of getting access, and we would like to talk to each center individually during the next ECO regarding the issues in that center. If there are no issues, no problem. But, please fill those forms and send it before the next ECO. Thank you so much for participating today.
Thank you. Thank you. Any difficulties, do call me with filling the form. Yeah, thank you.